Hello, City Club, and welcome to today's forum. My name is Blair Garland, Senior Director of Community Relations and Marketing at OSU Cascades, which is City Club's Community Partner in Education annual sponsor. And I'm honored to serve as the President of City Club's board. City Club would not be here without the generous support of many. I'd like to give a shout out to our other annual sponsors. Please give a virtual round of applause to our platinum sponsors, St. Charles Health System and Brooks Resources. Our gold sponsors, ASI Wealth Management, Pacific Source Health Plans, and First Interstate Bank. Our partner in higher education and workforce development, COCC, and our silver sponsors, Ameriprise Financial, BBT Architects, Kittleson and Associates, Miller Lumber, Mosaic Medical, the Lucier Center, and Transformation Systems International. Today's live stream is made possible by our partnership with Connect Central Oregon, a nonprofit launched with the assistance of the OSU Cascades Innovation CoLab. So I'd like to share some exciting news. We're looking forward to our September forum when we will be back in person. Yes, we'll be back in person at the River House, and we can't wait to see you in September. For those of you who are unable to attend in person, we've got you covered. City Club will continue to live stream our monthly forums so you can watch live. And remember, you can always view our recorded events on our website. Now on to today's program. There's a wide range of ethical and policy issues to confront as the US and other parts of the world move to reopening. Recent news illustrates some of the dilemmas associated with COVID-19, and I'm sure you've heard about them daily. Today, we have the rare opportunity to hear from someone whose job it is to think about big picture realities in the bioethics realm. So please be sure to have your questions ready. Moderating today's program is our very own board member and program committee co-chair, Kat Mastrangelo. Kat is the Executive Director of Volunteers in Medicine. Kat, I pass the microphone to you.
Hi, I'm Kat Mastrangelo, and I'm the Executive Director of Volunteers in Medicine and a very proud City Club member and co-chair of the program committee. Today, we have with us Dr. Jeffrey Kahn. We have a rare opportunity to hear from someone whose job it is to think about big picture realities in the bioethics realm. Dr. Kahn is the director of the Johns Hopkins Berman Institute of Bioethics, a position he assumed in July of 2016. From 2011, he has been the inaugural Robert Henry Levi and Ryda Hecht Levi Professor of Bioethics and Public Policy. He is also a professor in the Department of Public Health and Policy and Management of the Johns Hopkins Bloomberg School of Public Health. He works in a variety of areas of bioethics, exploring the intersection of ethics and health science and policy, including human and animal research ethics, public health, and ethical issues in emerging biomedical technologies. Dr. Kahn has published 4 books, over 125 articles in bioethics and medical literature, has appeared in TEDx talks, and speaks widely, both in the US and abroad. He is featured in the Netflix series Unnatural Selection. For today's program, we might hear terms such as immunity passports, vaccine hesitancy, individual rights, and public good. There are a wide range of ethical and policy issues to confront as the US and other parts of the world move to reopening. Recent news and events illustrate some of the dilemmas associated with COVID-19. We hear or read about them daily. Some of the questions we might hear answered from Dr. Kahn include, should children under 12 be required to wear masks at school? Can we require healthcare workers to get vaccinated? Can a business require unvaccinated customers to wear masks? Please let me introduce today's speaker, Dr. Jeffrey Kahn.
Thanks, Kat. It's a pleasure to be with you. Thank you for the invitation. Greetings from Baltimore, Maryland, where I sit. But I should say, in addition to the kind introduction that Kat offered, I should let you know that I'm a born and raised member of the West Coast community. I grew up in Southern California. I left to go to graduate school on the East Coast after college at UCLA. So it's nice to join you on Pacific time. There are lots of topics to talk about here, as Kat offered in her introduction. I'm going to organize this a little bit in a kind of order of the way the pandemic evolved and some of the work that many of us were involved with in trying to respond to it and taking account of some of the ethical issues. And I think it will end up being a kind of bookend, because as far as we have come in the course of the pandemic, some of the things that we started with back in March of 2020 are in fact back with us as we enter the summer of 2021 and head into the fall. So let me begin by reminding us all that in the early days of the pandemic, in the spring of 2020, we were confronting what was pretty clearly a very infectious respiratory virus. So one that could be spread by air. We didn't quite know how infectious it was and whether it was literally floating in the air or required some kind of aerosol. But it seemed pretty clear it was and is a respiratory virus. And that among the challenges would be tracking the people who were infected in a way that might actually help us blunt the spread. So that's known in public health as contact tracing. And it's long been a tool of people who do public health practice, right, at the local, state, and federal and global level. So when there's an outbreak, contact tracing is a really important tool. Pardon me. Generally speaking, it's used when there are things like sexually transmitted diseases, sort of much easier to track down people who have had sex with others, at least should be in theory, than it is somebody who's breathed on another person in a public setting, right? That sort of makes it pretty obvious that contact tracing for some kinds of infectious disease is just easier to take on than it is for others. And I mean, just to offer a kind of in-between version, when there's an outbreak of a foodborne infectious disease at a restaurant, the public health professionals swing into action and they try to track down the people who have eaten in that restaurant and then figure out what the thing was that made everybody sick. So that's another form of contact tracing. So with a respiratory virus, it's really hard for the human-powered kind of contact tracing to be effective. By the time you figure out that somebody is sick, and SARS-CoV-2, right, the virus that causes COVID-19 illness, by the time individuals are symptomatic, they have been infectious for sometimes many days. And so they won't know that they were infecting other people. They did so, unwittingly, unintentionally. And when you ask them, where were you the last week in ways that you might have spread this infection, it's incredibly hard for them to remember that. And even if they say they do, they'll probably not be terribly accurate about it. And so we were confronted with not only a very fast spreading virus through the air, but one that was not isolated to any one part, one city, one town, one restaurant. If it was a foodborne outbreak, it's everywhere. It's global. It's when people are traveling, they're taking it with them. And so we were confronted with a scale and pace of infection that people just weren't familiar with, right? It's a once in 100-year pandemic. That's not an exaggeration, right? The flu pandemic of 1918 is the most recent experience with something on this scale. And so long way of introducing one of the first ethical issues that at least my group worked on, which was, what do we do? How can we bring 21st century technology and approaches to bear on contact tracing, which has been around forever, but is done via human power? And so one thought was, we're all carrying around computers in our pockets, right? Little very powerful computing devices, which are with us all the time. Why can't we take advantage of the fact that those devices can probably tell us where people were in proximity to other people in a way that we could do what became known as digital contact tracing. So your phone could be used as a way of keeping track, and this is where it gets into interesting ethical questions, keeping track of where you were and when you were in proximity to other phones. So using Bluetooth, it turns out, your phone can talk to other phones, trading, it's a handshake effectively, and you can, technology companies can set the parameters of how that handshaking will work. So how close do you have to be to another phone, your phone to another phone, and for how long is a way of trying to sort of figure out what's the infectious distance and over what period of time. So if Kat and I are in a bar together for 15 minutes and sitting within 3 feet of each other, there's a pretty good chance if one of us is infected, we're infecting the other, right? So that's 3 feet of distance for some period of time, let's say 15 minutes. We're probably talking to each other, we're breathing on each other, we're not wearing a mask. Early in the pandemic, that wasn't even happening. And so that makes a lot of sense. But what if the same thing were true and you were outside? Much less clear. What if we were at a soccer game for our kids and standing within the same proximity for the same amount of time, but we probably wouldn't be breathing on each other in the same ways if we were in a bar and we are not in an enclosed space. So it's a kind of a technology question about how to do it. And then what to do with the information is where the ethics questions start to come in. Okay, so as you all know, I'm sure there are two mobile phone platforms, right, in terms of the software in the world. One is Apple and the other is Android. So there's the Google environment and there's the Apple environment. And so those two technology companies, for the first time in their history, agreed to work together on this problem. And they created a way to allow states, it turns out, to turn on the ability on, and to have you as an individual turn on the ability in your phone to share information with public health if your state decided it was an acceptable thing to do, and then use that data, that proximity and time related data with the Bluetooth handshakes to determine whether you might have either infected other people, if we know that you were a SARS-CoV-2 positive case, or that somebody reported a SARS-CoV-2 positive case and you might have been in proximity to them, so you might be infected. So there's a way that we could use technology to help us do this thing that had been analog for the last 100 years, this contact tracing idea. And so we got asked early on to evaluate the ethics and policy and governance issues related to that technology. A long way of introducing these issues. Really interesting questions. First is, well, wait a second. It's a different matter for many people to pick up the phone when it rings and hear somebody on the other end say, hello, Mr. Kahn. We think you might have been exposed to X, Y, or Z disease because you were at this place or interacted with this person at this time and they are sick. Can we come and talk to you? Or can you answer a few questions on the phone? That's one way it happens. The other is somebody shows up at your door and knocks and says, hello, Mr. Kahn. Somebody we think you had sex with is positive for this sexually transmitted disease. We want to test you. And generally people, they don't love that, but they don't react terribly badly to it. They appreciate what's happening. It's a very different thing when data from your phone is being shared somehow with the government of your state for the express purpose of public health, but we don't really know exactly what else is being done with it, right? It's a very different matter than the phone call or the knock on the door. And so what kinds of protections should be in place so that the data that's collected in the way I've described would be used for the legitimate and reasonable public health purposes, but for nothing else. And the other things that it might be useful for could include everything from tracking where we are, so our geolocation information, which could be interesting to our governments, or a lot of people in the country carrying around mobile phones in their pockets. It could be monetized in ways that I'm not smart enough to even suggest, but Google and Apple certainly are. And so that ensued a very interesting dance about what was the way to strike the right balance between protection of privacy, which we all care a lot about, especially in countries like ours, and what we're doing this for, which is public health, to blunt the spread of this very infectious and pretty bad disease caused by the infection. So public health on one hand, privacy on the other. And the challenge was we can't just say do whatever public health demands to help blunt the pandemic. We could say that, but that would mean sharing our geolocation information, where we are 24/7, who we're interacting with, at least in terms of the handshakes of our phones with other people's phones, with the government in ways that when the pandemic was first becoming known and then raging, we were not at a high point in the trust in government. We remain not at a high point in the trust in government. But those were maybe, the pinnacle of mistrust in government. And so we spent a lot of time and wrote a book, in fact, about how to do this in a way that would be most effective. You might say, well, that seems like not a lot happened. And the truth is we spent a lot of time, and a lot of other people spent a lot of time on related topics, and there was not terribly large uptake in the use of the technology at the state level. So among the things that our system requires is, if the federal government doesn't decide that there should be a federal approach, the CDC invoking by some public health emergency powers, that everybody should have this turned on their phone. It will be collected in some national database and then shared with public health authorities. If that doesn't happen, and it didn't certainly in 2020, then each state is going to have to do that, make a decision about that on their own. And predictably enough, some states were early adopters, other states were somewhat later adopters, and other states didn't ever decide to do this. And we're, I think, just over half of the states eventually turned on this ability. And you might say, well, okay, that's fine. So the people of Oregon do or don't have this, turned on for them. And states like California, probably similarly, it's like, okay, California doesn't matter to us much whether Nevada or Oregon do or don't. But I live in a part of the country where I can, in 1 hour in my car, be in Pennsylvania, West Virginia, Virginia, Delaware, the District of Columbia, and Maryland, where I live. And so all of those states, should try to talk to each other, but they didn't. So we were faced with this really interesting governmental sort of, what should governments do? How can we get them to work together? What's the ethically acceptable way to behave in this context? And how can we help convince state leaders that this is the right thing to do and you should all do it? We actually tried without a lot of success. And the upshot, and I'll maybe, either pause or go to my next topic in a moment here. The upshot was the state leaders who needed to make the decision about this, who were elected officials, made a decision that privacy and protection of information on the part of individuals was much more important than serving the public health goals. So it wasn't really contact tracing, it was just anonymous information will be uploaded to a cloud-based server. And if you turn on the ability on your telephone and you report that you have a positive test, that will get uploaded to the server, and then all of the phones that were within the parameters set by your state, 15 minutes of time, 3 feet apart, in the time that you were deemed to be infectious, will get an anonymous ping. There'll be nobody in public health will know who gets pinged, whether they get pinged, where they are, when they get pinged. It's all being done in an automated way with nobody collecting that information or knowing anything about the people. So it sort of takes public health and the work of public health out of the hands of the public health professionals and gives it to the citizens themselves. You are responsible for reporting when you get a positive test, and then you're responsible for doing something about a ping that comes to your phone. Not a very effective way to carry out public health. So it didn't work, hasn't worked so far. Second problem, I said I would stop, but I was not being honest with you. A couple more things. Second problem is the technology was and is controlled by Google and Apple, not by state public health or state governments. And so the governments could say, and public health professionals in the governments could say, it would work much better, Apple and Google, if you would allow the functionality to do this additional stuff, like send the information to public health. But Google and Apple had to agree to do that. And their interests were somewhat public health, but mostly about whatever's interesting to them from a business perspective, whatever they deem to be their interests from a business perspective, which don't always, maybe, don't often square with public health interests. So we had technology companies effectively dictating how this technology ought to be used in a public health context. And to put too fine a point on it, but during a once in 100-year public health pandemic emergency. So it seems really odd that at the end of the day, the decisions about how to manage a public health emergency from a technology perspective got decided by Apple and Google. That doesn't seem exactly how we would want to do it looking forward. And then the last thing I'll say is really about sort of the way infectious disease works, which is all of this seemed well and good when there was a little bit of a manageable amount of circulating virus in any particular community. But at some point, the numbers were so big and the spread was so fast that technology and human-powered contact tracing just got overwhelmed. You just couldn't hire enough people or make the technology work well enough or fast enough to actually do anything about the spread. And so it's only a workable approach when there is a sort of threshold below which the virus is circulating. And we may be back to, this is the bookend part, maybe back to that level now that we're through the worst of the pandemic, hopefully, and vaccination rates are where they are and hopefully will continue to increase. There will still be circulating virus because we won't reach herd immunity anytime soon. And so maybe it's time to bring back the discussion of how we use technology to help us manage the ongoing incidence and prevalence of the infection in communities. So that's big issue number one. Technology brought to bear in managing and responding to the pandemic. So one example is digital contact tracing. I have another, but maybe I'll pause at this point if you want, Kat, and take a drink of water, one, but also ask if there's any follow-up or anything we should talk about.
Well, yeah, I do have a question actually. So talking about, the technology is controlled by private companies. So even if we wanted to access it, there's a different level of control. But what are some of the business ethics around the use of that data, but also, touching on social media and monitoring information and disinformation in a public health emergency or really any kind of emergency that we might have?
Yeah, these are really good questions. And, I would say there's one thing that's at stake here, which is trust. And so, and sort of, where is trust? And when we're talking about information either gleaned from technology or shared via, as you've said, social media. And I think we've learned a lot about the challenges during the course of a public health emergency, as you say, or any emergency, when misinformation seems to be rampant and sometimes intentionally, right, is shared and put into the information and social media environments. And that's really hard to figure out, like, how do we guide and who's responsible for doing so? So we're back, I think, to the high level question is, Apple and Google have a lot of power. We already knew that. Facebook, I would include if we're talking about information sharing, and Twitter, right? All these companies have a huge amount of power. And I think we're realizing that a conversation needs to happen about how what are the appropriate parameters for that power gets used, and how do we assure trust in a trusted source when there's an emergency like the one we've just lived through for 18 months. I don't think we have a good answer to the question, unfortunately. And I worry that we are not in a much better place in terms of trust in government, trust in information, trust in public health than we were at the outset of the pandemic. So that's going to be a many years, I think, effort to rebuild trust in entities like the CDC, which used to be without any question the gold standard in the world for trusted public health information. The same people work there now as did before, but obviously many things have happened, and part of the upshot, I guess, the cost of the way that there's been information in the global environment over the last almost 2 years now, is that entities like the CDC, the World Health Organization on a global level, are not trusted in the same way. And it's not to say that they should always be thought of as the most trustworthy, whatever they say is 100% accurate all the time, but we do need some trusted sources of information when we're facing questions about what to do as a matter of public health.
So what do you think has changed? You know, the CDC, the Surgeon General, you know, a generation ago, we came up with seatbelt laws and drunk driving laws and smoking in public places. And those were seen as protecting not only individuals, but those around them. What has changed since we were able to have those types of public health related policies become the law, and why is that different now?
And when we still have those laws, right? Those haven't been
Right.
removed from the books. And maybe, you know, that's a really helpful question to give me the opportunity to do a little more framing from an ethics perspective of how to think about things like contact tracing or things like, you know, seatbelt laws, if we don't want to talk about pandemic. Like we're all tired of talking about pandemic, but, you know, generalizing from what the last 18 months has taught those who don't focus on public health about the importance of public health. So there's a challenge always in a liberal democracy like the United States, like Western Europe, you know, like the countries around the world that have elected governments like ours, of balancing individual liberties of rights, the rights of individuals, right, to do what they see as best for them, right? So that's protection from infringement on the right to do what you want. And we in the US in particular hold those kinds of rights. They're called negative rights in philosophy. So I don't know that we talked about the fact that I have a PhD in philosophy. So this is when I start to talk like a philosophy professor. Those are called negative rights, the rights to be left alone, or a liberty. Liberties are negative rights. So those are just synonyms. And those are the things that we have enshrined in our Constitution. The Bill of Rights is a list of negative rights. So the rights from protection from interference by the government in individuals seeking to do what they want, right? Freedoms, that's another term for liberties. Freedom of speech, right? The government can't infringe on individuals' freedom to speak as they see fit. On the other hand, just a little bit of a counterpoint, a positive right is a right of positive provision. So we have freedom of speech, right to speak out, but we don't have a right to say to the government, and you need to give me the podium and the microphone. That would be like the positive provision part of a right to speech. So we have the negative part, no infringement on individual liberty. And there's a list of those, right? We talk about right to bear arms, religion, all the things that we know are in the Bill of Rights. And so public health comes along and is effectively challenging those, right? Because public health is about the health of the public, as it's, the term would imply. It's not about individuals deciding for themselves. It's about how do we protect you as an individual, but everybody around you as well, as you put it. And so public health is always sort of in tension with individual liberties. And the question for governments and public health authorities and people like me is, where's that line? Like how can we, when do we cross it, and for what reasons? When is it a good enough reason to infringe on individual liberties? And certainly I think people who work in ethics and public health would say a public health pandemic, a once in a century pandemic that threatens the life of people who are infected with a respiratory virus, seems to be a time when we would say, yeah, you have a right to go out of your house without a mask on, except when, we're confronting a public health emergency. And so that's where the conversation about digital contact tracing gets really interesting, because you could say, Apple, Google, we don't care that your business interests are, that we shouldn't do anything but share anonymous data, right? Collect anonymous data, sorry, not share it. Because you don't want your reputation to be tarnished as the company that shared private individual information with public health authorities. That's not something we should think about when we're talking about public health. We need to do what's in the interest of public health, and that may mean infringing on individual liberties and accessing information about where individuals were, who they were in contact with, and whether they're infected or not, as a way of blunting this pandemic, which has got all sorts of not only benefits for the individuals who will hopefully protect and keep from getting sick or treat earlier than they otherwise would have, but prevent the spread, and also allow businesses to remain open, children to go to school. It has all these sort of follow-on effects that aren't really typically thought of as public health, but that are values that are really important too, which are the consequences of public health policies and practices. And so the core argument from the very beginning of this pandemic has been, how much infringing can we do, fill in the blank, of individuals, of businesses, of schools, of groups of certain kinds of people and not others. What can we allow to go forward? What should we make sure don't happen? Across a whole range of things: air travel, public schools, sports, concerts. The fact that we spent a huge amount of time and energy to make sure that the NBA season could happen inside of a bubble effectively, is sort of an example of that. All right, so all by way of saying that's sort of the politics, public health, ethics conversation that's been happening, not just during the pandemic, but before. That's what we have been doing in my institute for many years. It just seemed all prospective until now. And now we're trying to figure out how to actually make it real, make it work in action, with some success, but also a lot of fits and starts, and a realization that we can plan all we want about this sort of high level stuff, but if we can't get technology to test a lot of people early on in a pandemic, none of that matters, right? We failed in a lot of ways that had nothing to do with this kind of decision making, had to do with the fact that we didn't have enough tests to figure out who was infected and who was not until way deep into the pandemic, which is a failure that should not happen in the first 20 years of the 21st century. That was a little bit of a ramble, but hopefully somewhat responsive to your question.
So we do have another question. We have a question from an audience member. Did any other countries use technology effectively for contact tracing? Yes. And a second follow-up question, were Apple and Google seen as the gatekeepers worldwide?
Yes. So yes and yes, but let me say more obviously than that. So Apple and Google were and are the gatekeepers worldwide, because those are the only two OS, right? There's only two operating systems for mobile phones. And maybe there's a few niche things that I don't even know, but right, everybody carries either an Android phone or an Apple phone. And so they are de facto the gatekeepers, and they weren't willing to sort of open up the API, as it's known, and the tech people in the audience will understand this better than I. They weren't willing to just open up the API and let the public health folks, do whatever they wanted. They were absolutely the gatekeepers worldwide. Other countries absolutely were more effective, but let me give you examples of which and why. So probably the most successful was South Korea. But it was not just the phones and what we ended up calling digital contact tracing that was effective. They also were able to effectively use the people's mobile phones to track where they were, not just in terms of exposure, but where they traveled, when they accessed the clinics in the national health system there, which is unlike what we have, a nationalized system. They were able to track credit card usage, where and when, and also cell phone, like text messages, as well as voice calls, and use all of that information to triangulate in all sorts of ways that made it really easy to figure out who was where, when they were there, and when there was a positive test to find people who were infected and act on it very quickly. So we were many, many steps removed from that. We were just talking about pings sent to phones and people then having to act on it, right? So that's a very kind of elementary version of what ended up being used in South Korea. We wouldn't be able to do that in the US, and I'm not advocating for it. That's effectively following the population using digital means. Israel did something very similar until it was struck down by the courts there. Singapore was quite successful, but it was because they required everybody to either have their phone turned on in the way that I've described, or they had to carry like a device on their person if they didn't have a phone, required by the government. And you're getting a sense of the kinds of places where this was effective, very different than the United States. And so, we tried to learn from those places that implemented these technologies earlier than we did in the US, but there was only so much translatability and remains so. There's a lot of work happening now about how we can learn from what worked and mostly what didn't. Not so much to help in the ongoing, winding down of the current pandemic, but really more for what happens next, for the next time that there's maybe a worse, not just worse in terms of spread, but worse in terms of fatality rates. Luckily, this was not as bad as it could have been.
So what about technology being used for things like vaccine passports? What are the ethics around vaccine passports, both for public entities as well as private entities?
So that was sort of my coming back to where we started, part of the introduction. So technology now is being talked about again in exactly the way that you just suggested, Kat. And I'm sure that folks who are watching are familiar with the fact that the European Union has announced a sort of green passport approach, is what they're calling it, where everybody in the EU bloc will have access to the same technology, which will allow them to show vaccination status and then cross borders in ways that will be not quite as free as it was before, which was, sort of borderless across the EU, but much freer. And we in the US are on the list of countries that are permitted to travel to the EU, somehow showing our vaccine status in this system, which we haven't learned exactly how that will work yet. So what are the issues? So one, maybe I'll just step back and say, it maybe doesn't matter what the issues are, because decisions are being made by countries and blocks of countries like the EU and private entities like airlines in particular, as well as employers, to go forward with some versions of this. So there's not really a debate to be had about whether or not to do it. Little sidebar about that is that you may have heard in the state of Florida that the governor has issued an executive order barring the use of technology like this in the state of Florida. And at least, I can't remember which of the cruise lines, one of the cruise lines has announced that if that continues to be the case, that they will stop sailing ships from the state of Florida and just take their ships elsewhere for bringing on passengers and offloading them, because they are not willing to accept passengers who can't show that they've been vaccinated. So it's going to be a fight that isn't about public health, but one that's about business and politics, unfortunately. The issues, however, are, I think, interesting in that we're having this, debate because we have the ability to get vaccinated, right? So it's like, what can we show to allow our lives to become freer? But in setting up a system like that, it restricts access and liberty to people who can't get vaccinated. And that's most of the population of the rest of the world. And most of Europe, actually, not just like the less developed parts of the world. So I think it's easy to forget that anybody who wants to be vaccinated above the age of 14 in this country can go today and get a vaccine. That is just not the case in most other places in the world. And so what we're setting up is a system by which the rich, the best off people in the best off places in the world will have the ability to do things that the vast majority of the rest of the world does not. So there's this incredible inequity that's being sort of reified and reinforced, not intentionally for that purpose at all, but rather, as a function of our trying to get back to something that feels more like normal. And so what do we do about that? I mean, one answer is, well, wait a second, my children can't be vaccinated because they're not old enough yet. Does that mean I can't go anywhere. So no, the answer is, well, you have to just be tested within a certain number of days of departing, and you probably have to be tested when you arrive in a particular place. It'll be much more difficult to do, but at least you're not barred, and that will be the way to sort of make it feel a little bit better. But we're setting up very much a kind of us-them situation in a way that doesn't seem like what we really want to do. That said, to be more localized about it, we at my university, and I think this is now becoming the vast majority of places, we're having a vaccine mandate for anybody who is coming to our campuses, which is all the students, faculty and staff are coming back in the fall. We were talking before we started that we're coming back to some hybrid version of in-person work starting the middle of August, and we're requiring everybody to show that they've been vaccinated or that they have a legitimate and approved exemption. So there's no excuse is sort of the argument. And people who say, I don't want to get vaccinated because I have a medical exemption or a religious exemption or some philosophical reason for not being willing to do so can come to work, but they have to wear masks indoors all the time that they're at work, and they have to be tested twice a week on campus. So it's a quite onerous work environment. And if people aren't willing to do that, then they end up, we're going to process, fine, you can go find a different job. You can't work here anymore. So we're setting up a really interesting dynamic and environment. And it goes back to the question you asked earlier. It's public health trumping individual liberties. And it's an example of when it feels appropriate because of the public health goal and the steps being taken and the programs being put in place are the least infringing ways to achieve the public health goal. It just turns out that there just isn't any other way, right? So the way we think about it in ethics is, what's the public health goal? What are you proposing to do to achieve it? And are you doing it in the way that's least infringing on individual liberties? And so that's the stepwise process that people are thinking through, whether you're a university, whether you're a nonprofit, whether you're a private company, whether you're an airline bringing passengers back on planes, whether you're a country deciding who can come across your border. And so there's a sort of common analysis. It's the sort of willingness to implement, I think, that's different, and it's very heavily influenced by politics.
So we have another question from an audience member. How has the loss of faith in public health officials and scientists during the pandemic impacted bioethics generally?
It's a really good question. So you may all know that during the beginning months and weeks and months, and really as it stretched out in the pandemic, Johns Hopkins became like a household name. You know, many areas of academia, we are very well known, mostly in biomedicine. And I would say the work that we do too, but that's a much narrower slice. But the nightly, whatever news you turned on, there was a statistic that day, and the little footnote said, Johns Hopkins University. So it was this sort of odd dynamic where loss of trust in what would have typically been the government's role of reporting that kind of data, the CDC, the Centers for Disease Control, which is a federal agency that does public health, that's what it's charged with doing, had so much less trust. Trust had been undermined intentionally by some. And so Johns Hopkins became kind of the trusted authority, trusted voice. And because my Bioethics Institute has always focused among its areas of expertise and interest on ethics in a public health context, we got thrown into that mix really early too. And so that combination meant that we were working incredibly hard from the very beginning. I was really worried when, like everyone else, we went home on a Friday. I forget the date, but I'm sure it was all the same for you. We went home on a Friday, and then we messaged everybody, over the weekend on Monday morning, don't come back to the office. I thought, how in the world are we going to do our work, and what work is there going to be for us to do? That was an unfounded concern. We had nothing but work, and have had nothing but work for the 17 months that have come since. And among the things we got asked to do was help with, the kind of policy decisions that we're talking about, Kat, but also stuff we haven't talked about, like what happens when the flood of patients shows up in our hospital, Johns Hopkins Hospital, pretty famous place, show up all needing, ICU beds and ventilators and other things that we hadn't actually thought about, and we don't have enough. Like, how do we decide who gets it? And that's an ethics question. That's a triage question, right? So bioethics has focused on that, but not so much on that particular question, a little bit, mostly about, well, we only have so many kidneys for transplant. We only have so many livers for transplant. We have so many lungs for transplant. How do we decide who gets them? And there's a very built up analysis and system by which we answer that question. But it's very different than too many patients showing up in the hospital all at once, which happened, luckily, not so often and not so many places. But where it did happen, these were really challenging issues, and physicians and nurses and other healthcare professionals, their job isn't to decide who will live and who will die. Their job is to treat everybody who shows up. And so we got thrown into that mix really early, and we worked really hard with our clinician colleagues and the hospital administration at Johns Hopkins for the state of Maryland. And because of the high level attention that Johns Hopkins gets both in medicine and bioethics, we were called from all around the country by our colleagues for help. And what are you doing? What policies are you implementing? Can we share? Can you send us what you're putting together? What can we learn from you? And we would say the same thing, frankly, like, we don't have any secret key here. Tell us what you're doing. Let's all work together. So that became a big part of our work for probably the first 4 or 5 months of the pandemic. And we were just spending hours and hours every day having conversations about how to do this. And in real time learning, well, it's not ventilators that are a short supply, it's dialysis machines, because people who get really sick with COVID-19 need kidney dialysis. That was not predicted. What do we do for children? All these features that hadn't been part of the initial planning, but that we were trying to deal with in real time. So it's very challenging, but very exciting, and very, for us, it felt like we were important, which, made it possible for us to work just crazy amounts of time, all like this, of course, too, all sitting and staring at screens, none of it in person.
Have you heard any discussion around possible higher insurance premiums for people who refuse vaccines? Kind of like higher life insurance premiums for people who smoke or skydive?
Right, I have not heard that. It's a really interesting question. And we don't have that. And, there's the interesting policies related to making sure that people who have pre-existing conditions of various kinds, and going all the way through to like genetic susceptibility or genetic, mutations that cause disease, they are not allowed to be charged more for health insurance. That said, life insurance, as you've indicated, disability insurance, other things that we buy on the market, people will, the companies are free to use that information, and increasingly do. So I haven't heard anybody getting charged more for life insurance yet, but that's an interesting possibility.
Okay, we have another question from the audience. From a public health standpoint, would it have been better to have had a national mask mandate, or was the state-by-state mandate the best? Or would something even more granular have been better?
I guess better, it depends on what better means. I think it would have been easier from a public health perspective for there to have been a federal level mandate. And also because federal messaging from one place, like if, I don't know that he's the right person, but everybody knows Tony Fauci at this point. If Tony Fauci were the person who was the voice for the administration and public health, this is what we should do, that would have been, maybe people wouldn't have all agreed, but at least it was a consistent message about what will happen, and that's the federal mandate. Still the case for airlines. I live in the Northeast Corridor, so those of you familiar with that, there's Amtrak service that runs between Washington and Boston. That's very heavy travel. And if you go on Amtrak, they're not messing around. They'll say, if you don't have your mask on, we'll remind you once. And if we see you again and remind you twice, we'll get a little meaner about it. But if we have to remind you a third time, we'll put you off the train at the next stop. Just done. And that's like really clear, and everybody keeps their mask on, right? So that isn't what happened, of course. Clearly there would have been pushback, state by state and probably locality by locality within states. And so there would have been, I guess, a different set of problems, which is why I'm saying at best, it kind of depends on what you mean. It would have been better from the perspective of consistency. And I would say, as I said before, I live in a much more dense area in terms of states, such that, we didn't know, this is true even as we got later into the pandemic and people started to go places. Like we went to DC to see friends. Like I didn't know what the masks rules were in DC compared to Baltimore County, Maryland, where I live. Not that I was going to behave differently, but somebody said, what are the rules here? Like that shouldn't be, right? That's confusing, that's not helpful. And so I think a lot of the problem with the, response to pandemic was confusing information. So to the extent that there can be one voice and federal level is the way to do that, that feels like a good way to manage these things to me. That said, there's a lot of mistrust in federal government. So maybe it would have been even less effective. I don't know.
So we have an audience member saying, what's waiting for us this fall? And I want to follow up with that a little bit. 2 nights ago in Bend at our school board meeting, we had an overflow crowd with parents who were wanting to know what the school board was going to do about requiring masks in the fall for kids. So we're not the only school district facing that. Can you talk a little bit about what some of the considerations are and maybe what advice you would give our school board members to consider as they develop their policy?
Yeah, this is a really complicated question, and everybody is talking about it, if not for their personal family reasons, then for, the community in which they live and the implications it has for the employees and things like that. So, the CDC just in the last week or 10 days issued guidance that they think it's safe to come back to school. Anybody who's able to be vaccinated can be unmasked, and all children unmasked, based on their expert thinking and guidance. And I don't have any reason to think that that's a bad idea. I do think many of us have come around to the idea that yes, it's not a great idea to have strangers sitting in a room together and then going home to their families because of the risk of infection, but that there are really bad consequences when kids don't go to school in person. And I live in Baltimore, as I mentioned, where in the city of Baltimore, a very high proportion of the kids in schools get fed in schools. And that may be the two best, the breakfast and lunch they get may be the two best meals of their day. And that's, a really important factor to consider. And there was all this work to deliver meals to people's homes during the pandemic as a way of making sure that kids got fed. So I think, that's a piece. Safety, of course, is a piece. Being able to go to your job without having to be at home to manage your kids' education on Zoom is an important piece. And all of those, I think, are now, starting to fall into place. The question will be whether we have to make decisions as the fall unfolds that change what seem like the reasonable decisions in prospect. So going back to in-person school, bringing people back to the workplace, and probably in some hybrid fashion, that's what we're doing, 3 days in the office, 2 days remote, that all makes sense in prospect. But there are still variants, Delta we all hear about that are circulating. There'll be other variants as people interact with each other more. The fall is when flu season comes. All of these things are going to matter. So having people out and about, I've talked to numerous people who said, I wasn't sick for 17 months and then I went out and I got this horrible cold, right? Because all of a sudden you're interacting with people that you didn't before. So all of this is going to matter. And so, I think the only advice I would have is, do your best and be willing. I think everybody's going to have to be flexible. And I know we've said this for the last 17 months and counting. but there probably have to be decisions that are different, in November, December, January than they are in July. And that's just going to be a feature of this until it's kind of the encouragement I would have, until we get to a point where we've got enough people vaccinated that this just stops. But we're far from that in many places in our own country, and certainly far from that across the world.
Mhm. Great. Well, we're about out of time, so I just want to wrap it up. First of all, um, this has been a really interesting topic. Just some of the issues around technology, around Apple versus Google, and the devices that we all keep in our pockets, and what some of the dimensions of the public versus the private use of that personal data, I think, is really interesting and something that I've learned about today. And then, just this idea of individual freedoms versus, our collective obligations in dealing with something like public health. So I want to thank you, Dr. Kahn, for taking your time out of your very busy schedule to participate in our program today. And special thank you also to our program committee member, Janet Greger, who was responsible for arranging to have Dr. Kahn speak with us today. Remember, if you have enjoyed today's forum and would like to help support City Club, consider becoming a member or a live stream sponsor at www.cityclubco.org. August's forum will be the last one that is live stream only. Remember, we will be back at the River House in September. City Club will continue to live stream our monthly forums, so everyone will be able to watch live. Also, to all of our members who have signed up today, we will be sending out our forum survey. We really encourage you to give us feedback on today's forum and other forums so that we can continue to improve what we're offering to our community. What are Ben's goals? How do we fund them? This is the topic for August. We will be joined by Ben's first publicly elected mayor, Sally Russell, and Councilor Megan Perkins as they talk about the 2021, 2022, and 2023 Bend City Council goals, the process, the progress tracking, and the funding for those. We thank you for watching. Please continue to cultivate conversations about issues that connect us all to build a strong community.